Hello and welcome to CEY 2018. My name is Graham Lakkis. Today I'm going to take you through a presentation called Visual Field Analysis in the OCT Era. The presentation will be in two parts. The first section will talk about why I believe visual field analysis is still important in the management of glaucoma, even in this era where we have excellent OCT equipment. And in the second part of the talk, I'll give you some ideas on how to optimize your visual field exam so that we can run very quick, efficient tests that give us a lot of information and make the whole process comfortable for our glaucoma patients. Too long ago, eye care practitioners did not diagnose glaucoma until a visual field defect was actually present. Even if there were suspicious disc cupping changes and neuroretinal rim thinning, if there was no visual field defect, often the practitioner would still call the patient a glaucoma suspect. With the advent of scanning laser technologies such as the GDX and HRT, as well as digital stereo disc photography, we were able to see that these structural defects were actually changing even though there wasn't a visual field defect present. With the advent of spectral domain OCT in 2007 with improved resolution, better quantification and comparison to a normative database, we were able to detect these structural losses even earlier and well before visual field losses were present. And gradually, practitioners have actually moved away from visual field testing. They've been using predominantly structural analysis with the OCT and rarely or infrequently using visual field testing. So really, in this day and age, is there still a need for visual field testing? Where do visual fields fit in? Well, let's step back a little bit. What gets damaged first in glaucoma? Does structure go first or does function go first? We truly didn't know till the OAT study came out in 2002, and it was able to confirm that structural losses were predominantly the first part of the eye that were damaged prior to functional losses. This was prior to the OCT development, so they used stereo disc photographs to check for structural changes, and they found that newly diagnosed glaucoma was detected by disc changes in 55% of the cases and by visual field changes in 35% of the cases, and in only 10% of the patients did they actually have problems in both optic nerve and visual field. Now, since OCT came out, we've got a better way to analyze structure than stereo disc photos. And a study has been done recently by Dana Bloomberg that compared stereo photos, visual fields, and OCT at discriminating glaucoma suspects from glaucoma. And not surprisingly, she found that OCT was better at predicting glaucoma than either disc photos or visual field testing. But having said that, a significant number of patients were still detected by visual field alone and weren't picked up by OCT. And in fact, there was one case that was not detected by either OCT or visual field, but was detected by changes on the patient's disc photos. Now, as I said before, it's rare to find simultaneous defects in both structure and function at the time of diagnosis of glaucoma, so please do not wait to find problems in both before making a glaucoma diagnosis. It can be in structure alone or function alone in a lot of the time. So, why can't we substitute structural tests for functional tests? Is there no correlation between structure and function? Of course there is, but the way we present the data means that it's very difficult to compare one to the other. For example, in picture C in front of you, we've divided the optic nerve into 5 superior and 5 inferior nerve fiber layer sectors, and we can overlay them on the typical RNFL Tisnet curve that you see. But if we, for example, look at sector 1 or sector 10 in the temporal part of the optic disc, and we correlate that to the visual field location on a 24-2 exam in section A, we can see that sectors 1 and 10 on the optic nerve only represent 1 point on the visual field in the 24-2. However, if we look at sector 7, sort of inferior and nasal, that represents about 13 points on the visual field. So there's not a direct correlation between RNFL sector on the disc and the number of points represented in the visual field. Also, if we have a look at the structure of the ganglion cells from the fovea outwards, we find there's a problem due to ganglion cell layering and density as we move away from the foveolar avascular zone. On a visual field test, if we get a 3 decibel reduction in visual field sensitivity on a point that's between the edge of the macula and the vascular arcades up in this region, that's associated with a loss of 10 ganglion cells. In that area, the ganglion cells are only 1 layer thick. However, if we go into the perifovea, a little bit closer to the central zone, a 3 decibel reduction in visual field represents a loss of 230 ganglion cells. That's a huge difference, 10 ganglion cells in this area and 230 in the other area. Therefore, there is not a direct link between loss of visual field sensitivity and the number of ganglion cells damaged. And if we think that through, it's quite possible that visual fields may be better at detecting more peripheral glaucoma damage because the OCT may not pick up a loss of 10 ganglion cells as well as a visual field unit picks up a loss of 3 decibels. In the early manifest glaucoma trial, this looked at patients that had established glaucoma and established visual field defects at the time of entry to the study, and they randomized them to treatment and to monitoring, and they found that there was a great importance of visual field later in the disease process. Once a visual field defect was already present, progression of disease was better detected by visual field changes rather than disc changes. Again, this was pre-OCT era, so they used stereo disc photography to look for structural changes. The reason for this is once you've lost enough ganglion cells, you no longer have spare capacity. At a point in space that's looking at a stimulus from your visual field unit, if there are 6 ganglion cells that could pick up that point of light, losing 1 or 2 of them doesn't change your sensitivity very much. But when you get down to the last 1 or 2 ganglion cells, if you lose one of those, then your visual field defect will deepen dramatically. So this is the data from the EMGT study. If we look at both treated and control group, progression was detected predominantly by visual fields and sometimes by visual fields and optic disc, but almost never by optic disc alone, very, very rarely. Now, if we have a look at this graph, which represents a comparison of both structure and function, on the vertical scale we have, for example, microns to represent ganglion cell complex or RNFL thickness, which in a normal patient is around 100 microns. And then on visual field, we're representing VFI, which also starts at 100% and moves down to 0. If we follow the blue line, we see that early in the disease process, loss of ganglion cells will lead to a dramatic reduction in thickness of tissue. But once we approach around 50 microns, 45 to 50 microns, the changes level out, because what happens is that the structure in the retina will never go down to 0. The ganglion cell complex or the RNFL will never revert to 0 because there are glial cells and astrocytes and other structural parts of the retina, such as blood vessels that will not allow the tissue to go down to 0. Conversely, as we said in visual field, because of redundancy of the cells, we can stay close to 100% visual function for quite a while. Once we've lost about 50% of our ganglion cells, then we start to get a dramatic reduction in visual field sensitivity, and unfortunately that can drop right down to 0 at total loss of vision and total blindness. We can look at this in other ways. In the left-hand diagram, we've got thickness of tissue in microns, and comparing it to the mean deviation or loss of sensitivity of the visual field, both for the nerve fiber layer and the ganglion cell complex. And we see that same scenario going on. We might start around 100 microns. If we lose 25 microns of tissue down to 75 and look across there, that's equivalent to about a -5 decibel loss in visual field sensitivity on the MD. However, if we lose another 25 microns down to 50, we're basically down to the level of blindness where we've lost 25 to 35 decibels of visual field sensitivity. And again, if we look at the picture on the right, where we've got the visual field sensitivity on the vertical axis and ganglion cell count on the horizontal axis, most of us have between 1 and 1.5 million ganglion cells at birth. So if we pick somewhere between, let's say about 1.4 million, if we lose half of those cells down to 700,000, that's equivalent to about a 3 decibel loss of visual field sensitivity. If we lose another half of that down to 350, then we're down to about -15 on the decibel loss of mean deviation, which is a significant glaucomatous visual field defect. So early in the disease process, not much change in losing ganglion cells on our visual field sensitivity, but later in the disease process, it's a precipitous drop in visual field sensitivity. So from that, we know that OCT is a little bit better in diagnosing early glaucoma, and visual fields is a lot better in more advanced disease once a visual field defect has been established. But as I said, a significant number of cases are missed by either of the technologies alone. So don't be tempted to use only OCT on glaucoma suspects. I've been sort of guilty of that myself. Sometimes I'll see a little bit of cup to disc asymmetry or slightly suspicious disc or slightly elevated pressures, and we'll run an OCT on the same day because it's quick and easy to do, and it comes up normal, and then I don't bother bringing them back for a visual field because I think if the structure's fine, they're probably going to be okay. But there are a significant proportion of cases where that's not the situation, and we really need to be cognizant of that fact and bring them back for visual field testing, even if it's on another occasion. So in practice, we really need to assess both structure and function and do it properly. If we have a look at the sensitivity and specificity of each of the tests, visual field on its own, which is the dotted line, doesn't do too badly. OCT does a little bit better with the dashed line, but if we combine the data from both, we'll find that we'll get an excellent sensitivity and specificity that's better than either of the tests alone. Okay. I think I've made a case that visual field testing is important to do at all stages of glaucoma treatment, whether they're glaucoma suspects, whether they have early disease or advanced disease. However, patients and practitioners hate doing visual field testing. I joke with my patients that the worst part of glaucoma is not going blind, but doing visual field tests, and the patients laugh at that because they know it's true. So what we need to do is develop strategies that minimize the inconvenience for patients while maximizing the amount of clinical information we get out of visual field testing. So you've got the patient now at the visual field unit. We're ready to program everything into the perimeter. What is the best way to proceed? Let's talk about that next. So first thing we have to do with the visual field after we've put in our patient's name and date of birth and spectacle refraction is what area of visual field testing we need to perform. There are a couple of options. Do we need to assess out to 60 degrees? That might be good because that's similar to what, say, Goldman perimeter was able to do in kinetic perimetry before we had automated threshold perimeters. It could look at 60 degrees, lateral and vertical away from the point of fixation. Problem with that is that it's very hard to get a threshold static perimetry value in the periphery. There are very few ganglion cells and the patient peripheral awareness is not very good and the threshold tends to be all over the place. Plus the testing time is huge because of such a large area and there's no progression analysis software in the Humphrey perimeter to check on 60-degree fields. What about a 30-2? That tests 76 points covering most of the macula close to the arcades. It's good because it covers about 6 or 7 or 8 points better in the temporal visual field area compared to some of the other testing protocols. However, it does take a longer test time. A 30-2 CETA standard is about 7 to 8 minutes. And like most of the Humphrey visual field tests, it only tests 4 points in the central 10 degrees, which I've marked in red here on the right. The 24-2 is another very commonly used visual field test. Tests 24 degrees around and 30 degrees out into the nasal step area, which represents the temporal retina. It's a little bit quicker than the 30-2. It runs about 5 minutes or so, 5.5 minutes with CETA standard. So definitely quicker test time. Again, the same problem. It only tests 4 central points and it only tests 4 points temporal to the optic nerve, while the 30-2 does, I think, about 8 points. What about the 10-2? That's also an option on your Humphrey perimeter. It tests 68 central points, which are marked in green on the diagram here on the right. A lot of practitioners say, why bother? We know glaucoma causes tunnel vision. We tell that to our patients all the time. It doesn't cause central vision loss. However, these days we're getting strong evidence that central defects can occur in glaucoma in the early stages of the disease process, and we'll talk about that shortly. The other option of a 10-2 is in patients who have already lost a significant amount of peripheral vision. You can use that to quantify their remaining central vision. And I feel that any patient that has A defect in one of those 4 central points marked in red on the 24-2 or 30-2 deserves to have a 10-2 done as well to quantify.